Dr. Brawley, perhaps we can start with you by describing the decline in cancer mortality rates and how much can be credited to behavioral change and early screening versus the medical advances.
Yeah. Interestingly, there's been a 22% decline in cancer mortality since 1991. Overwhelmingly, that is due to a behavioral change, and that is smoking cessation in the 1960s and 70s. Screening is actually not as important as improvements in treatment. Screening is important, but it's important we not overstress it. For example, in colon cancer, screening has decreased colon cancer death rates in randomized trials by about 35%. It's decreased colon cancer incidence by about 20%. Earlier today, we heard that colon cancer is totally preventable. I don't think the clinical evidence supports that.
And Dr. Yak, you spend a lot of time thinking about the most effective ways to encourage changes in healthy behavior. So perhaps you could give us an overview of what data there is to support which programs, what are the most effective, both cost-effective and effective in terms of outcome in trying to change behavior among employer populations.
Great. Thanks, Charlotte. Well, I think the first point I must say is it's wonderful to be here and to have a chance to talk about prevention. I was waiting for most of the day to hear that, and except for the discussion on colorectal cancer screening, it was hopefully lacking. And just to remind people of what we just heard, that this will have the biggest impact on the cancer burden now and in future if we strengthen prevention. The workplace represents a huge opportunity. Obviously, you've got a captivated force of 160 million people at work in America. And effective programs really are very much the mirror of the kind of work that the American Cancer Society has done for years, except they can probably go further than the general public health programs. So starting with a tobacco-free environment, supporting tobacco cessation and the use of a range of reduced risk products will probably have the single biggest effect on long-term cancer rates that you can do. Providing easy access for adequate screening and not doing too much screening, but doing the screening that really makes a difference. Looking at the food environment, making sure that you provide the vaccines that have impacts on cancers. The framework with which you do them in the workplace is really important. And we've seen, certainly from the experience of which of our clients have the biggest declines in terms of risks, McKesson being the one that comes to mind the most, because tomorrow night they receive the award of being the best workplace health program in the nation, based upon actual data of declining rates of tobacco, high levels of screening. And what seems to work best is when you combine a mixture of behavioral economic measures, economic incentives, with the use of good technologies to encourage and support people to have behavior, and a long-term goal of encouraging people to actually maintain and increase their health status over time, so that they feel the reward of doing things that often in the short term they may not want to do. That combination seems to be able to have a big impact on most of the major determinants of cancer, as well as of cardiovascular disease.
And so perhaps you could give an example of a program that has particularly good data around cancer prevention?
Well, we don't distinguish between cancer prevention and cardiovascular disease and diabetes and many of the other risks, because we know that the common risk factors for cancer, cardiovascular disease, diabetes, and chronic lung disease are virtually identical. And I think that's a very important message. If you really want maximum integration, go for the risk factors that are going to have the biggest impact. So McKesson's study, for example, showing over a 3-year period, pretty substantial declines in overall healthcare costs, driven on the back of good tobacco control, good screening for some of the major cancers, healthy food programs, activity programs. One of the things that I was surprised at coming from the public sector into this was the fact that we often underplay the role of physical activity. And you could say, well, what's the link between physical activity and cancer, besides some of the smaller effects on colon cancers? The thing about physical activity in the workplace is that it allows people to gain efficacy about engaging in the other more complex behavior changes. So we find that once people start engaging in a physical activity program, they're more likely to take up the tobacco cessation program. They're more likely to be screened on time and do many of the other more complex things that actually contribute to cancer control.
If I can just add, the combination of obesity, high caloric intake, and lack of physical activity, the three combined, it's a three-legged stool, in the next 20 years will be the leading cause of cancer, surpassing tobacco. So prevention is really important there.
So Dr. Parmar, at MD Anderson, you have 3 priorities for prevention. So what are those priorities and how have you been rolling them out?
So again, thank you for inviting me here. I think that at MD Anderson Cancer Center, it's really unique because it's one of the major cancer centers that actually does have a focus on prevention. So the 3 major targets or the 3 major challenges include smoking prevention, awareness against sun tanning, and to create an environment where people are able to have improved breast cancer screening. So actually, in the setup of MD Anderson, we have a separate clinic for cancer prevention and screening, but not only within the walls of the institution, but also how do we extend it beyond. So one of the examples is the Aspire, which is a web tool made in collaboration with the University of Texas Health Sciences. And because they involve the local younger developers and younger students, the effect of it or adoption of it is much wider. And this is a tool that allows for the young teenagers and the school-going children to actually have a analysis of how smoking can lead to poor outcomes and how it can actually develop or lead to cancer. So this is an interactive way of developing awareness. So it's not like a unidirectional lecture, it becomes more like a gamification. And we feel that this is a major development in a cancer center because usually it's very dictatorial and it's like this is right, this is wrong. But by giving them a seat at the table and making them have more participation, it's leading to a much more deeper penetration. So that's basically what we are doing.
Dr. Yak, how do you thread the needle between paternalism and trying to encourage employees to do the right thing? So Dr. Parmar referred to that a little bit in what you just described, but that sort of heavy-handed nature versus gamification or trying to find other ways to incentivize healthy behavior.
Well, there's this wonderful term that Cass Sunstein, who was the chief regulatory officer in the White House for a number of years and author of the book Nudge, really termed called libertarian paternalism. I think what we all want is we want choice in our lives. But we do, if we're really honest, we would still like a bit of nanny behind you to support you to do the things that you're not going to do in your best interests. And so the role of government is really important to set the scene, to make these choices easier. But we now have the opportunity for people to be much more choice-specific in personalizing the type of prevention. And we find that getting that balance right is absolutely critical. So an employer encouraging the employees to take part in these healthy activities isn't forcing them to do it, it's encouraging them. The use of incentives are not there as bribes to try and get people to force them to do things, but they're there to overcome our innate inability often to overcome a short-term desire to do something that is not in our best interest. We often don't select the healthiest food when faced with a range of alternatives. We often don't get out of bed and go for a run or go to the gym early in the morning. You need a nudge, you need a support, and that's what the economic incentive is there to do, to get you over that first lump. The concern in some quarters would be, well, is my employer going to know about all of these behaviors that I'm doing and what I'm not doing? And the answer is that certainly in our programs, I think all the others that are starting to evolve, the issue of privacy is seen as paramount. And many of the programs are being designed explicitly to address these privacy concerns from the word go. And whether it's fearful of knowing that the Fitbit device is going to let your employer knowing whether you're meeting your steps, or whether we had Yaron give a great presentation, and by the way, the company he was referring to, I'm thrilled to say, is our company. Looking long-term down the line, will we be trying to use genomics in some way to steer people towards more effective treatment? The privacy controls in that setting have to be beyond reproach. Is the public going to be assured of that? Are there still going to be people who are fearful that people are looking into the bedroom or looking into their kitchen or looking into what they're doing? I suspect there will. But what will start reducing the concern is when they feel the practical benefit in their own lives, when they see that this is actually contributing meaningfully to them leading healthier lives, their families are seeing it, their healthcare costs are going down, and it's having a material impact, as opposed to often what may be seen as more gimmicky type of approaches, which may give you rewards for aromatherapy or foot reflexology and a whole range of things, which probably don't have the material impact of a strong tobacco cessation program, as an example.
What a contentious idea. The more legitimately controversial is the question of screening, and the United States Preventative Services Task Force, USPSTF, if I'm getting my acronym correct, they have issued a series of recommendations that have been met by uproar over the past, 5-6 years, both on mammograms and on PSA tests. Dr. Brawley, maybe you could speak to how you see the debate around screening evolving. We heard earlier in the day someone refer to upcoming research on PSA, so maybe that will illuminate this debate further. But as it now stands, what do you make of it?
Well, I think that the American people actually really do think screening is far greater than it actually is. And that's part of the reason for the debate. In the case of screening with mammography, we've got good data, and there's very good agreement among professionals that screening mammography decreases relative risk of death by about 20% for women over the age of 50, and perhaps a little less than that for women over 40 to 49. Translated, 80% of the women who are going to die from breast cancer will still die if they get good mammography, good diagnosis, and good treatment. Now, in the United States, about a third of women with breast cancer don't get good diagnosis and good treatment. That's a logistical thing that we can fix. We can't make mammography better. The thing that we need to be talking about is not should we be screening with mammography, but how are we going to find a better test that's going to save all those lives that we accept as professional screeners mammography is not going to save. Now, in PSA screening,
that was a very complicated and sophisticated dodge, by the way, to my question, which was, should mammography now, as it now stands, should women 40 to 49, should they be having regular mammograms?
I think women 40 to 49 should be aware of the proven risks and proven benefits of mammography, and women 40 to 49 need to make that decision for themselves.
Okay, so now continue. Thank you.
At PSA screening, we've got two very large studies, one European, one American, both with tremendous flaws. The American study showed that PSA screening did not save lives. The European study, which was done in 7 different countries, has been reported as a positive study, but when you unpeel the onion, it shows that PSA screening saves lives in Sweden, but not in the other 6 countries. I don't know what a man is to do. Know that the harms of PSA screening are actually currently better proven than the benefits, but there may very well be benefits. And your guess is better than mine is what I would tell a man in front of me, although I will tell you, I don't know a PSA screening expert who's trained in epidemiology who will admit that he gets screened for prostate cancer. Many urologists get screened, but not the epidemiologists who are trained in prostate cancer epidemiology.
That's very interesting. Dr. Yak, maybe, and then we'll go to Dr. Parmar. On an employer basis, figuring out what to cover, how do you see companies dealing with this question?
Can I just make one comment before that regarding the screening for 40 to 49-year-old women? Mm-hmm. So I think it really brings up a very important point because there's a lot of information that's out there in terms of this particular subset. And we truly know that there is a subset of patients that are truly at high risk. Mm-hmm. So one of the things I would like to at least mention is that at our center, there is a separate clinic that is run once a week just for women who are at high risk, because you can just imagine how much of anxiety that's out there, information and misinformation. And if you type it on the web, like somebody had mentioned earlier, Dr. Google, there's so much of stuff coming at you. So having a moderator or having a physician who is expert in breast cancer or in genetics actually talk to these patients on a regular basis, or having them seen even though they have not developed cancer, to advise them when this should be done and how it should be done is very important. So what people are missing is that intervention or that regular checkup can never be replaced by the information or the guidelines that are out there.
And some women who are at extremely high risk should actually get MRI screening and not mammography screening as well. That should be mentioned.
Dr. Yak?
So, I mean, it's an incredibly complex question. I think we also had a very exciting time, having listened to the sessions earlier. What is striking between the way we're answering and the discussion that you had was that you're getting much more specific. You're starting to go to the subcellular level and the genomic level. We are still at a very blunt level of saying screening good or bad, when I think you're all saying that treatment is actually dependent on the cell type and the underlying gene of the genetic background of the person. We're going to have to merge these two approaches and realize that there's not going to be one answer for all. And the answers we're giving now are for large populations. So to do that, what we certainly do is we have an external advisory board chaired by the previous head of the International Agency for Research on Cancer, Peter Boyle, who's with his team around the world have done some of the largest epidemiological studies and help us assess whether we're going to support and what type of cancer screening we're going to support. Knowing full well that we are providing relatively crude advice to a large population, we're not providing the clinical advice needed when an individual patient with a particular family history, with a particular background both to their cancer as well as to their risk profile, may very well need something different. And that merger is becoming increasingly possible as the data analytics capability and our knowledge improves. And I would suggest that 10 years from now, we will not be having all or none screening for people. It will be very much answered around the answer, which I learned in medical school, is the answer to any question: it depends.
If I may, what we really need to do is move from a mid-19th century definition of cancer, which is what we've been using for the last 160 years. It was given to us by the Germans in the 1850s using autopsy material, and they worked out how you do a biopsy and that sort of thing. 160 years later, with all our new technologies, I can find a 5-millimeter lesion in a woman's breast, send it to a pathologist who does the same thing the Germans did to it in 1853, looks at it with a microscope that now has an electric light bulb as its light source, and says, this looks just like what the Germans defined as cancer 160 years ago. Now the question is that 5-millimeter lesion genomically programmed to grow, spread, and kill, or is that 5-millimeter lesion genomically programmed to stay 5 millimeters, or actually to wither on the vine, and because it can't get blood supply and actually regress in size? Eventually, we're going to be able to do genomic studies to say, Mrs. Smith, you have what is technically a cancer, but it's the kind that's never going to bother you. We actually already know that's about 30 to 40% of women with localized breast cancer who we currently cure unnecessarily. Or Mrs. Jones, you have the kind of breast cancer that clearly needs to be treated, and thank goodness we found it when it was small and very treatable. That's the future, but we're not there quite yet.
So how do we get there? So, and then I want to take some questions from the audience. But so the Illumina's test is, I'm sure someone out there knows the exact figure, but sub $1,000 now. There's 23andMe, which does different tests. On a population level, how do we think about getting to that future that you just described, where it's really individualized assessments and then individualized treatments?
We desperately need clinical trials.
I think it's really an explosion of information. The very first speaker was talking about the future, and then there was all this discussion about patients owning their own data. And now that getting an analysis is so much more cheaper and accessible, patients are overwhelmed with this information. So I think that the right way, at least now, to address it, that it has to be interpreted and it has to be acted upon individually. People talk about precision medicine, people talk about precision learning. I think we are probably moving towards precision screening. And I think that, as Dr. Brawley had mentioned earlier, that we are somehow following a definition that was established a few years earlier, and moving forward, we may have to constantly re-engage and constantly move the needle to understand that how these understanding of our diseases is changing, and accordingly, those kind of testings have to be readjusted as well.
So any questions from the audience for our panelists? Everyone thinks we have prevention down.
I think
yes, in the back. Someone will come right to you. So we'll do,
There's two.
There are two. We'll go from one to the other, back to back. Thanks.
How does one deal with the reality that 80% of men at the age of 80 on autopsy have prostate cancer, and almost as many women at that age upon autopsy, independent of the cause of death, have breast cancer? And the fact that the age-adjusted mortality from breast cancer didn't change at all, one bit, until maybe 20 years ago.
I don't have a total answer for you. I do believe that there are things in diet, things in our environment that actually cause those prostate cancers to grow in some men and become very clinically significant, and actually perhaps cause some men to have who have a small prostate cancer, the environment in their body may cause it to not grow. And we need to figure those sorts of things out. I don't know, Doctor.
Yeah, no.
I think I would totally support this statement, and from my field, at least I can tell you that we look at cancer as a two-hit hypothesis. So you have obviously genetic predisposition, and then you have environmental factors, and there is microenvironment. What we have seen is that in certain subset of blood cancers, a person may be carrying a specific mutation, but unless and until they are exposed to a certain environmental toxin or environmental area, it may not lead to the actual phenotype. And I think that it goes across other subset of cancers as well. And I would also like to take this opportunity to talk about secondary prevention. And what people don't understand is that people or patients who develop one cancer may be at risk for developing another cancer, and how important it is to have control over nutrition, over environment, and how do we educate them. And it's a constant process of learning because it never stops. Just like life is going on, these kind of mutations are also going on. And one of the fundamental differences that has happened, especially with the immunotherapies and all that, is a shift of frame. So, you look at cancer, it's an enemy, we must destroy it. On the other hand, you shift the frame a little bit and say, cancer is like an annoying neighbor. You get to live with him or her, but basically you develop a tolerance. So a lot of development and a lot of progress that we have seen in the field of cancer is from being able to educate the patients to live with it and control it for a long period of time.
So yes, right in, you're still ready for your question? Oh, you've been robbed, but we'll get to you next.
Great discussion. I'm a radiologist, and the size of my annual W-2 form depends on the fear of the public most often. I want to ask this question, which is that it's very easy to point out that those that are high risk ought to be screened, but what about those that are low risk? How do we persuade them not to be screened, or should we persuade them not to be screened?
Tricky question, particularly if you see CMS's responses to some of the USPCS task force recommendations, but Dr. Brawley?
The screening that we should be doing, colon cancer, by the way, about 50 to 55% of Americans get screened for colon cancer over the age of 50 right now, or are up to date, which can be a colonoscopy every 10 years. If we could get that to 80%, when we got the steady state, we would prevent about 12,000 colorectal cancer deaths per year. So colorectal cancer screening is something we should be doing. We can still do a lot in cervical cancer. We also need to be talking about HPV vaccine. We can do mammography is something that does save lives. I want to make that very clear, and it is very useful, but we need a better test. Then the people who are at high risk for lung cancer should be screened, or should at least consider screening. I think those are the things that we ought to be focusing on. And you said people who are at low risk. The studies that show that those things work were done on people at average risk. And I think that as folks know that, perhaps they will be a little bit more open to getting screened.
Elad. Oh, appropriate.
I think one of
yeah.
the other, and I'm just taking a cue from you, is when I was a fellow, it was very different scenario in terms of the accessibilities. Now what happens is that, husband turns 40, the wife bought him MRI at the mall, or CT scan at the mall. Now suddenly you have these dots or you have these shadows that the person is obsessing about, and then he goes to internet and there's tons of things. He ends up getting tons of biopsies. So I think one of the major things for cancer prevention and screening is education and proper information, so that the patients are not misled and people are not undergoing unnecessary investigations. And I think it has to be done, and ACS is doing a great job, but
thank you.
we can all help. Yeah,
It's a very tricky thing, because at the one hand we talk about patient empowerment and having so much more information and being able to self-monitor as being a really positive thing, and then you're talking about this counterproductive. So how do you balance that, Dr. Yak?
Well, I think the real challenge is that the whole call for breakthrough cures, which is out there, I can't remember how many times I hear it today, is what really excites individuals. They get alerted about a new breakthrough preventive screen or a new breakthrough cure. What we don't do well, either through the public media and through the health-related media, is let people know that, first of all, most of the breakthrough screening and new treatment diagnosis they hear about happens when we actually don't know what to do with the results, and we don't fully understand the consequences of the screening test, which means that you basically are screening people a decade before you can do something effectively with them. And what does that mean? On the one hand, it means rapidly increasing healthcare costs, greater anxiety among people who may be well or may not be well. And then you hear the story about breakthrough cures. You very rarely hear about breakthrough preventions because they sound so mundane. And I think that the balance of what the public are hearing these days is so heavily distorted towards the message that there's a breakthrough cure coming down the corner for cancer. We've actually, the theme of this meeting is on, there's a war on cancer, that it's blocking out the fact that we've got tried and tested what sound like mundane messages, but that have brought the cancer death rate and incidence rate down dramatically, as we've seen from all the ACS and national data. And it starts with good, effective tobacco control, where we're seeing a resurgence of new approaches to reduce tobacco control. We're starting to see the greater roles of vaccines. We're starting to see better evidence on healthy diets and activity as being beneficial, not just for cancer, for cardiovascular disease. Those core messages don't get the sexiness, don't have the sexiness and attractiveness in the media because they don't sound like breakthrough messages, but they're the ones that are saving lives day in, day out, in, year out. And the breakthrough cures should be put as the cherry on the top on what is going to come somewhere down the line that's going to give us hope, but it's still not here today. We're not doing that very well.